What about the laparoscopic pancreatic duodenectomy? For sure, this is a debating topic. If for distal, most of the authors are in favor, even for malignancies. For head pancreatic lesions and for Whipple procedure, there is some reluctancy. And reluctancy comes from the slow progression compared to distal pancreatectomy. And there are technical challenges which are much more formidable than for distal pancreatectomy, including dissection near major vessels, removal of the uncinate process. You notice that this is a somehow difficult and maybe dangerous part of the operation, and reconstruction of both biliary and pancreatic ducts, which when they are small, so involves important technical challenges. So the earliest series of laparoscopic pancreatic duodenectomy involved patients with small, benign or low-grade tumors of the pancreatic head, duodenal ampulla, and distal common bile duct. But in recent series, there are also patients with carcinoma located at the distal bile duct, pancreatic head, and uncinate process of the pancreas, and the duodenum and the duodenal ampulla. This is a study from 2015, published in Annals of Surgery, so we, which says that minimally invasive versus open pancreatectomy for cancer, practice patterns and short-term outcomes, and refers to 7,061 patients. This is one of the largest studies. Was performed in the United States using the National Cancer Database, and analyzing these 7,000 patients, the number of minimally invasively approach operations were 983, which means an adoption rate finally of 14%. 14% probably, I would say, this is the maximum that we can expect today for this operation in the world. I'm not sure that in the near future will be different. Initially, the portal vein invasion was a clear contraindication to minimally invasive procedures, but today there are surgeons able to do even the venous reconstruction. You can see in these images, portal vein resection and reconstruction during a Whipple procedure. The current status of minimally invasive pancreatic duodenectomy, there are 8 meta-analyses in the world, including the robotic approach, and we can see that here, if we analyze the surgical technique, this studies including the robotic approach. Here is only robotics, including robotic approach. So it's a combination of laparoscopy and robotics. That's why we, under the umbrella of minimally invasive approach, we debate more or less both of them, with robotic gaining ground because, as I mentioned, the sutures are easier, and somehow the versatility of the instruments can offer some advantages. Coming back, a systematic literature review of the laparoscopic Whipple. This is a study published by Ugo Boggi with also a significant number of cases, 746 laparoscopic pancreatic duodenectomies. We see the difference between 1997 and 2011, 400. And between 2012 and June 2013, 341 between 97 and 4 years, 14 years, sorry. And then in only 1 year and something like this, 400 cases, so a dramatic increase between 2012 and 2013 of the number of cases. It's pure laparoscopy, robotic assistant, laparoscopic assistant, and hand assistance, but a clear proliferation of the minimally invasive technique. At least in this period of time, in the 2016, we may be back, and we may register a setback to the open approach. But at least at this moment, when the study was published, comparing this period of time with 300 Whipples, with this period of time much shorter with 400, was a clear tendency to increase the number of procedures. The results, the laparoscopy procedure was associated with shorter operative time, reduced blood loss, low rate of pancreatic fistula. Again, this, as you can see, is comparing pure laparoscopy with laparoscopy assisted. Also, laparoscopy assisted is associated with shorter operative time, but with higher blood losses, increased incidence of fistulas. And conversion was required in 9.1% of cases. Another conclusions of Ugo Boggi's study: operative mortality 1.9, including 1 intraoperative death, and no difference in conversion rate, incidence of fistula, morbidity, and mortality when comparing results from larger and smaller cities. Well, oncological outcome. This is a study published in Journal of the American College of Surgeons in 2012, showing that significant differences favoring laparoscopic pancreatic duodenectomy were seen in intraoperative blood loss, transfusions requirement, length of hospital stay, and length of ICU stay. Operative time was significantly longer with laparoscopy. There were significant differences in number of lymph nodes retrieved in favor of laparoscopy. And this is the first study to show that there was also a trend towards more patients receiving adjuvant therapy after laparoscopy, because the delay after surgery was less. That's what the authors conclude. Now, coming to the crucial issue of cost. Laparoscopy managed to make it finally to break even more or less with open surgery, but still when a refined analysis is done, the conclusion is that the laparoscopy has higher cost than open surgery, than open pancreatic duodenectomy. Not to speak about robotics are even higher. So therefore, both mini-invasive major procedures are more expensive than open procedures. The learning curve for laparoscopic pancreatic duodenectomy is considered 50 cases. Of course, difference between high and low volume centers in favor of high volume center, needless to say. Now, some conclusions about minimally invasive technique for pancreatic cancer coming from some studies. So, conclusion: the location of the tumor within the pancreas remains the most critical factor in the use of laparoscopy. So, the left-sided are more prone to mini-invasive. Lesions in the body and tail, which are readily dissected with a distal or subtotal pancreatectomy, should be performed laparoscopically, unless there is a clear reason why not. Lesions in the head of the pancreas have been shown to be removed safely and effectively with laparoscopy, but this is more debatable. How about robotic? The state of the art said that robotic approach for pancreatic resections had significantly gained spread during the last 10 years. Malignant diseases most frequently treated by robotic approach are pancreatic and periampular adenocarcinoma for pancreatic duodenectomy, and ductal adenocarcinoma, neuroendocrine tumor, and pancreatic metastasis for distal pancreatectomy. Robotic approach for pancreatectomy is superior to open approach regarding intraoperative blood loss and length of stay. The benefit of robotic on operative time, early morbidity, and oncological result is not demonstrated. Robotic approach could facilitate splenic preservation during distal pancreatectomy, and despite facilitation of lymph node dissection and reconstruction during pancreatic duodenectomy, the benefit of robotic approach for this operation remains to be demonstrated, maybe in the future. In summary, several laparoscopic techniques for pancreatic surgery have surged in the last 10-15 years. I'm not sure about 2016. In selected patients, staging laparoscopy could avoid the need of laparotomy in up to 50% of cases. Pancreatic tumors have been shown to be removed safely and effectively with laparoscopy, and may also have several oncological advantages. However, the technical skills necessary and the ability to teach this to trainees remain to be limiting factors to widespread use. Robotic surgery could lead to a wider acceptance of mini-invasive surgery in pancreatic surgery, especially in procedures requiring reconstruction. So, little bit different answer than the initial one to the question, is this the future? Probably, but slowly. Thank you very much.
Thank you, Professor Popescu, for your speech. You kill us with all this huge review of the minimal invasive pancreatic cancer. I don't know if the floor, anybody have some question about this topic? Yeah, one question.
I think it is, you showed clearly that we have a lot of study done on, or series reported on minimally invasive surgery. But the problem is that when we look to the conclusion in this study are not driven from the result. The conclusion are the hope of the surgeon that laparoscopy should be. One of the 2 or 3 last study you showed, the conclusion was made that left distal pancreatectomy should be the reference unless there is a reason. I mean, nobody can state this. We can say can be done, but should be done unless the open should be justified. I mean, it is a too strong conclusion, not based on the result of any study, because all the laparoscopic technique in randomized study in whatever type of surgery, they have never been shown superior to open, at least equal, but not superior to open surgery. So this is the problem of all these studies, that surgeons want to do laparoscopy, so he write the conclusion that laparoscopy is better.
I only would like to add another question for you, because in the
but answering this question, so
yeah, because in the article you can find also the author that concluded the laparoscopy is in a shorter time of operation. I don't know how is it possible, and less rate of pancreatic fistula. And I don't know why the laparoscopy can, in any case, present less pancreatic fistula. Thank you very much.
Thank you. So again, these are the data, and it's difficult to comment on them because, if we doubt the validity of those data, I think it might not be fair. Anyway, we can comment. But I will try to answer Professor Adam's question, asking you a question. If you remember, the last year left pancreatectomy is performed in Verona. So how many were performed open and how many were performed mini invasive? Approximately. How often do you do the open approach for left-sided lesions?
Really approximately, but more or less we are performing 50% laparoscopy and 50% open, because we perform open for all the adenocarcinomas, so that the carcinoma, apart from very selected cases that are very in the tail of the pancreas, small tumors, this is another bias that we were talking with Soren. Of course, you have a better prognosis because we operate in the laparoscopy the smaller beta carcinoma, so probably they have a better prognosis than open. But we approach to laparoscopy to the neuroendocrine tumors in the body tail and to the cystic lesion, not all the cystic lesion, but the majority of the cystic lesion. So probably half laparoscopy and half open.
But for adenocarcinoma?
Yeah, he answered.
Adenocarcinoma.
Yeah, so this is a clear answer.
5 or 10%.
Yeah, and that means that that statement was an overstatement. We have to take it, and we have the answer. Okay, thank you.